Thank you for that kind introduction. As someone who was involved in developing this concept of reverse innovation, I must say I've been delighted to see that it's provoked a lot of discussion. When we coined the term, and even as we put out papers through review, we got a lot of pushback from reviewers that the term didn't quite seem appropriate. But our intent was not really to settle the matter, and certainly we didn't intend to be ethnocentric. I mean, we are two guys from India. I mean, how ethnocentric could we be in the West? But we intended that it should start a discussion, and it's very clear that it has. The main point was that the needs of emerging markets are very different from those of the advanced countries. Those needs have become very visible in today's global economy, and therefore we need innovation to address those needs. Once you innovate for those markets, and it doesn't mean it is all done by only people in those markets, there is an opportunity then to diffuse those innovations to other parts of the world, to other emerging markets, and sometimes maybe to the advanced countries, sometimes because there are poor people in rich countries, and sometimes because there are innovations that you develop for the emerging markets and then discover that they have value in other contexts as well. I never in my wildest dream ever imagined it would provoke or inspire to be set to rap music. So, Dr. Chen, you're obviously a man of many talents. Now, I want to focus today on this topic based on some research we've done in India on innovative healthcare delivery mechanisms and some of the hospitals that have led the way in that process. What you see in this slide is Dr. Devi Shetty, who is the founder of a heart hospital, which has now become one of the largest heart hospital in the world. He was trained in India, then went and worked overseas in the UK, came back to India, worked in a heart hospital, and discovered that the needs in India were so enormous that he really had to do something about it. He was also inspired along the way by being the personal physician to Mother Teresa. And all of this sort of came together with this passion to create high-quality healthcare for the masses at very low cost. Now, in that sort of description of the challenge, you can see why emerging markets like India can be important incubators, important laboratories for innovation in healthcare delivery. You have tremendous need. Hardly 5% of the needs of the population are actually being served. You have people who often have to pay out of pocket, very often pay the entire cost of healthcare out of pocket. That means you have to keep prices low. On top of that, their capacity to pay is very limited because you're talking about a poor country for the most part. Even the middle class cannot afford outrageous costs of healthcare. So you have this combination where you have to provide access to a lot of people who don't have access. You have to provide quality care, and you have to keep the prices very low. Now, these three elements, access, quality, low cost, these are exactly the three things that we wrestle with in the advanced countries. How can we improve access? How can we improve quality? And how can we keep costs down? The only difference between the poor countries and the rich countries is that the pressures to innovate, to meet these three attributes are much stronger because you have so many more people and with so much sort of much more limited capacity to pay. Now, what Dr. Devi Shetty did in terms of starting this hospital was not that unique, it turns out, because we started digging deeper. We discovered that there were other doctors in India who had similar motivation. And one of the interesting things we are discovering is that poverty is actually a fantastic setting to stimulate breakthrough innovations. Poverty has many bad aspects to it, but one of the great things about it is that it can prod people and motivate people and empower people in ways you would find very difficult to do if you're only dealing with an affluent population. So what you see here, and I call them India's doctorpreneurs, they are doctors, but they're philanthropists and they're entrepreneurs, all rolled into one, and they have pioneered hospital and healthcare in a number of different fields. One of the characteristics of this innovation process is, of course, that the prices in India are very low for many healthcare procedures. And you can see in this chart, I know it's kind of hard if you're sitting in the back to read it, but let me just summarize for you that on the first column, you have a number of different health conditions, whether it's cataract surgery or open heart surgery, going all the way down to cancer treatment and maternity care and so on. And in the second column, we just look at the prices at some of these innovative hospitals compared to prices in the US. And they range anywhere from 1% of US prices to 15% of US prices. In other words, it's anywhere from 85% to 99% cheaper to undergo these procedures in these Indian hospitals. Let me state at the outset that we're not saying all Indian hospitals are like this. We're not saying that India is a model for the world on how to care for its population, provide health care for its population. Anything but. The opposite is true. Most people in India get very poor care. But in that setting, there are a few hospitals that are actually doing some very creative and innovative things. And these are the hospitals we're talking about. Now, when you see these kinds of low prices, whether it's hip surgery or knee replacement or cancer treatment, two explanations immediately come to mind about why are they so cheap. The first is it must be because the quality is poor. Now, I don't have time to go into this in much detail, but you see here one chart from our article comparing the outcomes for two of these hospitals. One is for breast cancer, the other is for kidney disease treatment, renal disease treatment, and they are comparable to that of US hospitals. Sometimes a little better, sometimes a little worse. And this is across the range of the hospitals we looked at, infections rates, survival rates, complication rates, readmission rates. They are as good as that in the average US hospital, sometimes even as good as some of the best US hospitals. So it's not because quality is poor that their costs are low. And this is one of the ideas that I want to sort of emphasize, what we've discovered in this research, what was actually already discovered before in manufacturing, that high quality and low cost are not in opposition, are not mutually exclusive. In fact, they actually reinforce each other, because efforts to improve quality can often reduce cost. And efforts to reduce cost often require you to improve quality. And that's what these hospitals have done. The other explanation that immediately comes to mind is that the cost must be low in India because salaries are low. And yes, salaries are low. For doctors, they're anywhere from 1/4 to 3/4 the price, the salaries paid to US doctors, depending on the specialties. But if you go down the hierarchy to nurses and then to some of the administrative staff, it is sometimes 1/20th or 1/50th the cost that you would pay in the US. So there is, in fact, a labor cost advantage. However, we took one of these hospitals, the heart hospital, that does open heart surgery for $3,160. This is the price it charges for open heart surgery for paying patients. This is not the cost. Their cost is actually $1,900. Their goal is to bring it down to $1,200 initially, and then to further lower it to $800. But $3,160 is what they charge for paying patients. We said, what if you took all of the employees they have and assume you paid them US salaries? Well, the cost would go up to about $13,700, but it would still be about 1/5 of prices in the US. So labor cost is not the complete story. It's an important piece of the story, but it's not the complete story. Now, keep in mind that some costs are actually higher in India than they are in the US. Land is sometimes in urban areas is as expensive as it is in the advanced countries. Imported machines actually cost more. Imported devices like stents and clamps and so on, which with import duties actually can cost more. So it's not completely a one-sided story of having low-cost position. So what then is the answer? We identified 3 kinds of practices that they use. None of it is rocket science. There's no silver bullet. I think of it as the Southwest Airlines approach to keeping costs down. In fact, it's very interesting when you talk to these doctors, They are inspired. You ask them, where do you get your inspiration from? They get it from McDonald's, they get it from Toyota, they get it from Southwest Airlines, and they get it from Walmart. These are the names you hear over and over again. I wonder how many hospitals in the US or in Canada think of these companies as their role models for innovation. Now, what do they do specifically? I'm going to try to give you a flavor for what they do in each of these areas. Start with hub and spoke. It's a simple idea. The idea is that you concentrate your most expensive pieces of equipment and your most sophisticated skills in hubs, and you put less sophisticated skills and equipment in the spokes, which are closer to where people live. So you're trying to balance providing the best possible tools, at the same time recognizing that you don't have all the doctors you'd like to have, you don't have all the equipment you'd like to have, you cannot replicate everything everywhere, you can't turn every spoke into a miniature hub. Spokes have got to be spokes. And this is illustrated in this example of eye care by one of the eye hospitals we looked at. It's not Urban, which also does something similar, but L.V. Prasad. And you can see here they have a 5-tiered structure, starting with primary care at the village level, where they have one vision guardian, they call it, look after 5,000 people. And then if they find a problem, they can refer them over to a service center, which is like the next level in the hub and spoke system, and further on, and so on and so forth, and ultimately up to the highest level, which would be a center of excellence in Hyderabad, which is a big city. Let me show you just what this might look like. This would be a typical vision center. It really can do two things. It can test someone's eyes using that expensive equipment, costs $7,000. That $7,000 is part of the $10,000, which the total cost of opening one of these centers. So the most expensive equipment investment is that one equipment. And the person operating it is called a vision technician, is not an optometrist, but can see if you've got problems with the eye that you need glasses, they can fix it for you right there. They can sell you glasses, or they can give you glasses if you can't afford it for free. And if the problem appears to be something more serious, they send you over to a secondary care center. Now you have to travel some distance to get there. You would get free care if you couldn't pay for it. And at this center, you have more equipment. And here they can perform cataract surgeries, but not more complicated surgeries. And if you need something more complicated, you would then go to one of the tertiary care centers or a center of excellence, where you would get really pretty state-of-the-art treatment. In fact, many of these hospitals we looked at are both education and delivery systems. So they're trained doctors, they do some research, very applied research, and they also provide care for their patients. Now, as a result, this particular hospital has been able to blanket the state of Andhra Pradesh with this hierarchy of centers of excellence going down to tertiary care centers, secondary care centers, primary care centers, and then the village guardians. Now, similar structures we're seeing in the other sectors as well, for the other conditions. Whether it's cancer treatment or open heart surgery, you can use the same idea. And one of the things that happens, of course, between the hub and the spoke is that you have telecommunication links. So you can provide remote diagnosis. So in this example, we're talking to a medical physicist. She sits in Bangalore. She's looking at the information, the nature of the problem for a cancer patient in a spoke. She designs the treatment. The actual treatment can be then delivered at the spoke, where they have chemotherapy and radiation facilities, but not all of the medical physicists that they can afford to replicate that at each of the spokes. A further advantage from the hub and spoke system, you can see that it helps to reduce cost. It reduces cost because you get a lot of volume, because you focus the most advanced work in a few places rather than spread it across too many different locations. And the eye hospital that I showed you earlier is one of the largest in the world. It's the second largest in India. Arvind Eye Hospital, which is one of the other hospitals we studied, is the largest eye hospital in the world. The open heart, the heart hospital I referenced right at the beginning, started by Dr. Shetty, has the largest number of heart surgeries per year of any hospital in the world. So you can see that these are like focused factories. They do a few things, they do a lot of them. And as a result of this, not only does cost go down, and by the way, they also use the equipment very efficiently. One CEO told me, you got to make the equipment sweat. And I thought that sort of summed it up well, because they're running the equipment 24/7. Some of them have give you lower prices if you come in the off-peak times. And for those who can't afford to pay or unable to pay, they might be then slotted into those hours. So whereas an MRI machine in the advanced countries might be used 4, 5, 6 times a day, these hospitals will use them 15, sometimes 20 times a day. So they're getting a lot more out of the equipment as well. But they also helped improve quality. And this is an important point. This is, again, my point earlier about how cost and quality are not in conflict. How does it improve quality? Well, it does 4 things. First, it attracts good doctors to your network, because they know if they go there, they'll get a lot of practice. Young doctors want practice. And these hospitals, because they are also educational institutions, they bring doctors in, put them through the training, and that gives them a year or 2 or more to watch these people and to pick the best to stay and work for them. So they attract some of the best talent. It also improves quality because they develop protocols, because they're doing lots of procedures over and over again, helps you to streamline the process. And because you want to keep costs down, it's very important to do it right. I had one hospital CEO tell me, we can't afford to get it wrong because most of our patients can barely pay for the procedure the first time. If you tell them now you have to come back and go through another procedure, they'll go bankrupt because they just cannot afford to pay. So again, this is a very interesting point about how poverty helps to improve quality because you have to get it right. And this is another important point that we think is often missed. The value for rich people when an organization serves poor people. We think the poor people are getting charity, and we think the rich are subsidizing the poor. And it's true. The rich pay higher prices. They go for all the frills. They pay for air-conditioned rooms and this and that. Use the profits from that to pay for the poor. What do the poor add to the rich? They add to the rich by adding volume. They add to the rich by giving you more chances to practice your skill and to perfect it. And then you can then do it for everybody, including the rich. So in that vein, another source of quality improvement is the capacity to specialize in rare conditions. So the reason I show you this picture at Narayana Health, this is their pediatric open heart surgery wing. They do more open heart surgeries on babies than any other hospital in the world. But that's because they do more open heart surgeries of all kinds than any other hospital in the world. And when you have that kind of volume, you can have large volumes even in rare conditions. And then you can have doctors who specialize in those rare conditions, and they can get to be very good in those relatively rare conditions. So they're now a magnet. They attract people from all over South Asia, from Africa, and so on and so forth. So the hub and spoke, therefore, produces all kinds of cost and quality benefits and allows you to expand your reach. Now, the other principle that I mentioned is task shifting, and I was delighted to see that one of the submissions picks up on the same idea. Task shifting is a very simple idea. It's how do you free up the most skilled people, free up their time so they can focus on the things that only they can do and the things that they can do well, and spare them this having to do all kinds of nonsense, which eats up a lot of time and which they don't even do very well because they're not good at that. So specializing and reallocating people so that doctors are freed up to do things that only doctors can do. And that's very important when you have a tremendous shortage of doctors. And this is one example here from the Arvind Eye Hospital, which has probably taken this to art form, is the lady who's sort of helping this gentleman test his eyesight. She is a village girl with a high school degree, and she's been trained over 2 years to perform certain simple procedures. 2/3 of the employees in Arvind Eye Hospital are girls like her. And they are all girls. And they're all from the village. And the advantage is they're very happy to have a job, because normally they would be waiting to get married after they finish high school. Now they have an occupation, they get a skill, sometimes a career that they can follow even after they get married. But more importantly, they're from the communities from where their patients come. 2/3 of their patients are poor patients. And these village girls understand the patients they're dealing with. So it accomplished so many different things. It's cheaper than even nurses. They provide good care. They're happy to have the job. They stay on for a long time. And they free up the doctors to do the most important things. And this is, of course, vividly seen in this photograph. It's not very clear, I know, because I took this through a glass window. But if you look, you will find there are lots of nurses in that room. Every eye surgeon is assisted by 6 nurses. And this allows the eye surgeon to just focus on the actual cataract surgery. Everything else, including bandaging the patient, preparing the patient, moving the patient, and so on, is done while the surgeon is operating on one patient. It's hard to see in that photograph, but there's a swiveling microscope, and this microscope just goes left and right as one patient is finished. The doctor swivels it, does not even scrub, washes his hands in antiseptic. I know this is going to make your skin crawl for many of you who are doctors. How could they possibly do this? Well, they claim it is safe. They claim that they have the evidence that it's safe. I don't know if that's completely true or not, but I say that for poor countries, you've got to think about this as an option. If the choice is between curing blindness and taking this risk, but they would never agree with you that there's a risk. But I'm saying this, even if you had to take a risk, and you can treat many more people if you do it more efficiently, then is it not something that we ought to think about? This hospital is inspired by McDonald's. Really, the doctor who founded it said, I would like to apply the McDonald's approach to cataract surgery. I want to give as many people cataract surgery as I possibly can in my lifetime. And that means I've got to study their methods. How do they deliver quality product consistently, no matter who's working in the McDonald's, at a low cost? And that's really all he's tried to do with cataract surgery. The third kind of innovation I put in a broad category of frugality. And this came up again in this concept of frugal innovation. What I have as an example here is a tertiary care hospital, 200 beds, cost about $7 million in capex. So the frugality is not just about being cheap. It's just not just about using the backside of a sheet of paper and not throwing it away. Yeah, they do that too. But what they are also doing is thinking every way to minimize capex and opex. And what they have done, for instance, in this hospital design is there is no air conditioning. They believe that you don't really need air conditioning except in the operating rooms. That in fact, air conditioning adds to capital expenditure, adds to operating expenditures, adds to complications because diseases get carried through the air conditioning system. So on multiple fronts, they think, again, this is lowering cost and improving quality. It's single-storied, therefore there are no elevators, therefore you don't have the capex of that, you don't have the maintenance and all of that. So this kind of idea they've taken on a number of different fronts. For instance, I mentioned to you that they use the equipment very efficiently. One of these hospitals has set a goal to double the life of the equipment. If the equipment is meant for 7 years, they say, well, we can use it for 15 years. And the CEO, Devi Shetty, has an interesting quote, and he says, we scrap our MRI machines after 7 years, but we fly an aircraft for 30 years. Now, if a plane can be fixed and run over and over again, why can't these machines? So, they're going to try to double the life of these equipment. They also try to save on consumables, on imported products, on clamps, devices. Wherever possible, they reuse them. Again, they reuse devices that are designated as single-use devices by sterilizing them. and reusing them 50 to 80 times, and thereby bringing down the cost like another $100 or $200 per surgery down to a couple of dollars per surgery. And this is allowed by Joint Commission International, provided proper procedures are followed for reuse, for sterilization. They've also innovated in ways to reduce costs by substituting costly imports with local products. And the best example, perhaps, of that is the intraocular lens that is used to remedy people with cataract surgery. And the product was first introduced in the West. It cost $200 a piece. Arvind Hospital decided to get into the manufacture of this. Today, they make them for $2 a piece. They export 70% to other countries. And so there's all kinds of innovations of this sort happening around these hospitals. The other aspects of frugality which are interesting, I think, is this idea of cost consciousness being created all across the hospital. Many of the doctors are employees of the hospital. So you don't have the system where doctors are practicing and are consultants in the hospital. Many of them are full-time employees. And I've heard people say that this is very important if you want to get the efficiency of the whole system. Because if you cannot schedule the doctors and the equipment and the patient, how do you take this line assembly approach to healthcare? I know it sounds awful. I know it sounds awful to say people are not patients, people are not unique, there are things moving down an assembly line. Hey, listen, but we all accept that with airline travel. How many of you would give up low-cost air travel if you could get better food on the flight and maybe overnight stay in a hotel when you're transiting, but you'd have to pay 10 times as much? We wouldn't. We would never want to go back to that world. But in healthcare, we're sort of stuck in this craft mode. We would like each one to have a personalized Rolls Royce when there's ways to make cars more efficiently. So these hospitals have been innovating on all of these different fronts in order to make healthcare affordable while still being of high quality. Now, the question I think we're left with, and I don't think I have an answer, is can we bring any of these innovations back? When we speak to people in the US, we don't pretend to be experts on the US, or certainly even less expert on the situation in Canada. All we ask is there something here that you can use? Is there anything you can do if the world remains the way it is? Is there anything you can use if you are a cluster of hospitals rather than a single hospital? Is there anything you can do or use if you have a province or a state which is more open to innovation? Maybe Alberta as the example in the Canadian case. So instead of thinking of this as a huge systemic problem that cannot be fixed unless the whole system is changed, because that's not going to happen, I don't think, in the US. What is going to happen is lots of little fires are going to be lit in lots of places, and eventually it's going to add up to become a seismic change, but it will not start as a big seismic change. I'll close by mentioning the example of the hospital I began with, which is Narayana Health, the cardiac hospital. They are opening a 2,000-bed hospital in the Cayman Islands, which will be an hour's flight from Miami. We know there are a lot of old people in Miami. There are a lot of also uninsured people in the US who would be happy to get health care at maybe a third of the price it is in the US. I won't go into the details, but what the hospital has found is that employers in the US are very interested in including this hospital as one of the options. And if you go to this treatment facility, there won't be any co-payments. They'll pay for your travel. They'll pay for a chaperone to accompany you. They'll give you a week or 2 weeks to recuperate in the Cayman Islands and a resort which will be right next to the hospital. So I know in Canada, sometimes you have a waiting list. You might want to think about this. Anyway, with that, I'll stop, and if there's any questions, I'd be delighted. And if you'd like to know more, please take a look at our article in the last issue of Harvard Business Review. Thank you.